Oh, thank you. And we'll have questions to the panelists after each one finishes their talk. Our next speaker is John Gabel. He's a senior fellow with the National Opinion Research Center at the University of Chicago in Washington, D.C. John is really known, he's best known for his survey work of employer health benefits, and he is the author of more than 130 published articles in scholarly journals and books, including 57 in the influential journal Health Affairs. John, welcome.
Thank you, Paul. Let me say it's an honor to return to the conference I consider the best conference I attend each year. And for that, I want to thank Margaret and Paul. And this conference, I think, is unique in that essentially we have the same speakers each year with the same audience each year, each sitting in the same seat each year. Now you know I am a compulsive public opinion pollster. So I'm going to ask a few questions. First of all, how many of you had breakfast this morning? Virtually everyone. Okay, well that is good because Gordon Gekko says lunch is for wimps. Now, more important, how many people here believe that the Supreme Court will overturn the ACA, particularly the individual mandate? Show of hands. Let's say the mandate. How many thinks it will not? Very interesting. Okay, now how many people think that the ACA will be repealed 1 year from today because we will have a Republican president and a Republican Congress? Show of hands. How many think it will not be repealed? Very interesting. So we will have to, so it sounds like from the audience we'll have to live with it. Well, it's, I'm sorry, and I don't mean it either way. I did not mean to condemn the legislation. Paul, I want to thank Paul, now that we know that the ACA will survive. Paul, I want to thank you for a lifetime of contributions. And particularly, I would like to thank you for an article in 1992 that you and 3 other conservative economists, Pat Danzon, Mark Pauly, wrote, which introduced to the country the idea of the individual mandate. Okay, let's see if I... Okay, these are this is my objectives. We want to document the state of employer-based health insurance. We want to examine changes over the last year and 5 years. And we want to examine the cost of the 2010 insurance reforms. And again, I'm presenting results from the Kaiser Family Foundation survey, HRET survey. Last year, we had 2,088 randomly selected public and private employers. We began the survey in January. We finished the field work in early May. Our response rate was 47%, and we used, as a probabilistic sample, we're able to use statistical weights to derive national estimates as to what a typical employer is doing and to what a typical employee faces. Now, I also want to present results from the California Healthcare Foundation Employer Benefit Survey, which we have. The California Foundation, I believe, began funding it in 2002. Before that, in 1999, Kaiser funded it. And I want to remind you that there are copies, actually, of the complete survey out on the desk. Do I have that right, Shannon? Yeah. They're out in the California Healthcare Foundation tape. Okay, good. Okay, now the California survey. It is a random survey. Last year we interviewed 770 employers with 3 or more workers. The questions are nearly identical to the national survey, but every year we add some questions not in the Kaiser survey and take some out from the Kaiser survey. This year we were in the field from July to October. We use statistical weights, and our sampling error with a full sample is about 3.5%. So let's go to the results. According to Kaiser, last year we had a spike in premiums from 3% to 9%. Now compare this to a 3.1% increase in consumer prices, and workers' earnings increased by 2.1%, not seen there. Now let me say about these results, I believe they're an anomaly. I believe somehow or other we got one tail of the distribution in 2010 and the opposite tail in 2011. Why do I say this? I say this because none of the other surveys are consistent with this. All the other surveys basically show little change in the rate of change, around 6 or 7% during that same period of time. And the other surveys, I'm thinking particularly of Mercer, I'm thinking of Towers Watson. So I am skeptical. I want you to also to note that the data for 2009 and 2010 shows a very low rate of increase in national health care expenditures. In nominal terms, about 3.9% per year. And as far as Medicare is concerned, we are finding that the increases in Medicare are at record lows per capita. Why this is occurring in Medicare, I cannot explain to you. Maybe others at the conference can do so. But for some inexplicable reason, Medicare seems to be having a record slowdown in increased costs. Now, it's easier to understand why we might have had a slowdown in the private sector simply because we are feeling the effects of the recession. But this is not what the 2011 data say from Kaiser. In California, the story is different. In California, our survey shows this, basically we've been at about the same level of increase each year, around 8%, 7 to 8%, and obviously this is not sustainable. I want you to, again, as I reminded last year, in Kaiser they changed the way we measured inflation. We did not change in the method we used in California. California pretty much uses a fixed basket approach. It's rather complex how we do it in Kaiser, but I'd be glad to, if somebody has any questions, I'll be glad to answer them about it. In California, again, the overall rate of inflation was 3.1%, but premiums increased 8.1%. So what is the cost of coverage? We are now above, for a family of 4, $15,000 a year. And if you think of the minimum wage, this is, I believe, more than the, is minimum wage seven, anybody know, is it 7 1/4? 7 1/4, so it's almost roughly equal to a minimum wage worker's earnings. If we look at the most expensive plan, it is the PPO plan. If we look at the lowest cost plan, it is the high deductible health plans at $13,704. Those figures do not include the employer contributions for the HSA, for the, what it's called here, high deductible health plans with a savings option. None of these figures are adjusted for the geography or the actuarial value of the benefits. They are unadjusted figures. And of course, we know that HMOs are very strong in California. They're strong in Massachusetts. They tend to be strongest in urban areas and high-cost states. Well, on September the 23rd, the first insurance reforms went into effect. They didn't go into effect till your plan year began. So in 2011, we start to see some of the effects of the insurance reforms. And here I want to focus on no longer could there be technical rescissions by insurers. Adult children up to age 26 had to be covered. No cost sharing for preventive services deemed effective by the U.S. Preventive Services Task Force, although this does not apply to grandfather plans. And somebody please explain this to me, because if that were the case, then for all those Catholic universities and hospitals, if they're self-insured, it doesn't apply to them. And an end to lifetime maximum and annual benefits, and annual limits do not apply. This adjustment does not apply to the individual plans. Now, at the time that the Kaiser, survey became public, the immediate response, of course, by some in the political community who are highly critical of the ACA was to blame it on these insurance reforms. We, and when I say we, I mean Towers Watson, my colleagues at Towers Watson, and working with us, we conducted actuarial modeling to say what were the additional costs. Now, when I say additional costs, do not think of this as inflation. This is like an upgrade in your car, and when you upgrade your car, it's going to cost money. So if we go over to the far side, well, first thing you see is most of these services are already covered in most plans on the group side. Not as true on individual, but surprisingly true in many cases. But if you look at on the far right, the increase in cost, and you look down at the very bottom, we're estimating that of the 9 points, 1.8% was added by the reforms of 2010. And what was the most expensive one? It was adding adult children. Adding adult children. The estimates are 2.5 million more adult children were carried on their parents' plan as a result of the legislation. And it had the effect of holding down the rate of uninsurance in the country. And here's just the long-term trend on uninsurance in this country. You can see around 2000 we were at 70%, and we're down to about 60.2% now of the population 18 to 64. And inevitably, of course, what is, we got a couple of factors that drive up the uninsurance rate. One of them is simply the cost of health care. And the second one is that as a percentage of the pie, workers today are getting a smaller percentage of the pie than they have historically. Their wages are lower. And of course, healthcare costs absorb some of the increase in wages that they would obtain. What kinds of plans are people enrolled in? The big story here is the continued growth nationally of the high deductible health plan with savings options. And when I talk to employer groups and I ask people who switched, why did you switch? And the answer I usually hear is because it costs less. And you can see on the other side, the HMOs in America, nationwide, are far less prominent today. Go back to 1996, when they were 27% in the market, and the point of service plans were about another 20%. If I'm reading that correctly. And now we're down to 17% in HMOs and 10% in the point of service plans. So nationally, we're seeing this movement towards high deductible health plans. And in California, it's a different story. HMOs are holding their own at 54% of the market. And the high deductible health plans only are 6% of the market. And I think we're finding that Kaiser and the models in California where people are used to low cost sharing, and where Kaiser can offer a very high benefit product at a comparatively low price, has made it much more difficult for the high deductible plan to find success in California. And according to the Kaiser survey last year, there was not much of an increase in employees' contributions for health benefits. It stayed at $77 for single coverage per month, from $333 to $344 for family coverage, and as a percent of the contribution, it actually declined. You can see there's 17% and 27%. Now, one thing that has certainly happened over the last 7 years is that the deductible that is faced by employees, including both those who are in plans with deductibles and those in plans without deductibles, we take the overall average, you can see it has more than doubled since 2005. From $266 to $670. And if we go back to the Rand health insurance experiment, what this surely means is people will use fewer services than they would without these deductibles. But we can also go back to the Rand insurance experiment and say that cost sharing, I think this is still the consensus, that cost sharing is a blunt instrument. It cuts out the appropriate and the inappropriate services roughly equally. And we asked last year, is your plan grandfathered? And you can see that the smallest employers were most likely to be grandfathered. And this is in terms of covered workers, mind you. Overall, the majority of firms will have grandfathered plans. So, of course, having a grandfathered plan essentially freezes you into your current design. And I believe logic would follow, if it freezes you into your current design, it should serve to slow down the rate of increase in premiums. Because, now let me back up. It will slow down the rate of increase in cost sharing. It may have the opposite effect as far as premiums are concerned. It will raise premiums, but it will keep cost sharing down. And then we asked employers, why was their plan not grandfathered? And we see, particularly for small employers, you see the fact that the plan was not in effect last year. You can see deductibles or co-payments changing, or employee premium contributions changing, being major reasons why plans are not grandfathered. Now, there's this continued belief in the employer community and the insurers that wellness was a way to control long-run costs. And you can see how, particularly among the large employers, how extensively they are invested in wellness programs today. 90% of large employers offer at least one program. The figures are much smaller for small employers, defined as under 200. There is provisions in the ACA that would allow money to go to small employers, to go to exchanges for wellness programs. So I will summarize at this point. Premium increases were 9% and spiked to the highest level since 2006. Take that number with caution. It just isn't consistent with the other data. We'll learn more on this year's survey. The ACA insurance reforms contribute 1.8% of the 9 percentage points, and the most costly reform was the provision for covering adult children, we're seeing this secular decline from about 70% to 60% since 2000, and the number of people adults covered by employer-sponsored health plans. Deductibles have doubled since 2005, and more than one-half of enrollment is in grandfathered plans. Now, I'm reminded of what Adlai Stevenson once said, which is, mankind does not live by words alone, although sometimes he has to eat them. So I will predict, I think you will see in the small employer market, in the individual market, and also in the large employer market, I think you will see the rate of increase declining over the next couple of years. So hopefully I'll be invited back next year and you can tell me whether I was right or wrong. Thank you.